the supranuclear disorders are clear or more easy now, because if you are just reading them alone, it will be extremely painful to understand. Okay, let's now talk about the ocular myopathies. So let's start first by the most important disease, which is the myasthenia gravis. So what is the myasthenia gravis disease? Myasthenia gravis is an autoimmune disease that is characterized by fatigability and weakness of the skeletal muscles. So those patients who have myasthenia gravis, they have generalized weakness, or they can have only weakness of the eye muscles, which is termed as general myasthenia or ocular myasthenia, respectively. So what is the cause? What is the underlying reason behind this weakness or this fatigability? This is because of the presence of abnormal antibodies. They are called anti-acetylcholine receptors antibody that destroys the acetylcholine receptors in the striated muscle. So let's assume that this is the nerve, which is like a third nerve or the oculomotor nerve. And this muscle is the levator aponeurosis muscle. And there will be like junction between both of them. This junction, it is called the neuromuscular junction or the synaptic cleft. At this junction, there will be release of vesicles of acetylcholine, which is the neurotransmitter for the parasympathetic system. And this release of acetylcholine will act on target action, which is the acetylcholine receptors, which is present in the muscles or present in the levator aponeurosis muscle. So in order for the levator aponeurosis to contract and elevate the eyelid, there should be release of the acetylcholine receptor, acetylcholine vesicles from the neurosynaptic cleft, and they should act on the acetylcholine receptors. In those patients with myasthenia gravis, those receptors, acetylcholine receptors, are coated with antibodies, anti-acetylcholine receptors antibody. So when the acetylcholine is released, it will not find any receptors to act upon, resulting in that there will be no action on the levator, resulting in that the levator will not contract, leading to weakness, leading to fatigability if it involves the whole or the other systemic or large muscles. So this is the pathology, or this is the pathogenesis of myasthenia gravis. It is due to autoantibodies that destroy acetylcholine receptors in the striated muscles. So does it involve the males and females equally? No. And it is as most of autoimmune diseases, they involve the females more frequently. So, and the myasthenia gravis is an acquired autoimmune disease. So usually the patients will develop the autoantibodies later on in life. So the autoimmune, it is not inherited. However, a congenital myasthenia gravis is also present. Like some patients can be born with congenital myasthenia gravis. It is not that common, or it is rare. However, it does occur. But in this case, it is non-immune and inheritable disorder. So this will be like a genetical abnormality that will cause defect in the contraction of the muscles, resulting in myasthenia gravis, but not of autoimmune nature. So what will be the peak age? This disease has a bimodal pattern, meaning that it has two peaks. There is a peak between the second and third decade, and there is another peak in the 6th to 8th decade. It is more common in females, like 3:1. And for those patients, or for females, this peak appears more frequently in the 2nd to 3rd decade. It's also worth mentioning that those patients can have associations with thyroid eye disease. Like in 5 to 10% of those patients, since they have autoimmune disease, they can also have autoimmune antibodies against the thyroid gland, resulting in thyroid eye disease, which is present in 5 to 10%. That's why those patients, we need to inquire and ask about the symptoms of thyroid disease in order to exclude it. Regarding the clinical presentation, one of the most important things about this disease is that the symptoms are common by the end of the day, meaning that it is characterized by fatigability, and this fatigability ends or increase by the end of the day. So if we ask the patient if they look more fatigued or they feel more fatigued by the end of the day, this raises the suspicion of myasthenia gravis. And for myasthenia, we have two kinds. We have the generalized myasthenia and ocular myasthenia. As we mentioned, it will involve the skeletal muscles. So if it involves like the skeletal muscles of the pharynx, it will result in dysphagia. If it will involve the skeletal muscles of the larynx, it will result in dysarthria. If it will involve the skeletal muscles of the respiratory muscles, it will result in dyspnea. So these are some of the general manifestations of myasthenia gravis. For ocular myasthenia, this is where the patient will complain to ophthalmologist. They will complain of what are the kinds of external muscles or the skeletal muscles present in the eye. They will be the levator muscle and the extraocular muscles. So for the involvement of the levator aponeurosis muscle, this will result in ptosis, and the involvement of the extraocular muscles will result in diplopia. If we wanted to summarize the diplopia and the ptosis of both of myasthenia gravis, then the hallmark will be the variability. They will be very variable. What does it mean by variability? For ptosis, it can be unilateral or bilateral. It can be partial or complete. It will change even in degrees during different stages of the day. It will be more at the end of the day. So it is very variable. This is an important key word here. So if you find like an exam, a clinical scenario saying that the ptosis is increasing by the end of the day or it is variable, please pay good attention or think of myasthenia gravis. What about the diplopia? How does a diplopia could be variable? Well, diplopia could be horizontal or could be vertical or could be torsional. So this will be due to, again, damage or due to affection of the extraocular muscles, which doesn't follow a specific pattern. So that's why you may read in the books that myasthenia gravis can mimic any ocular cranial nerve palsy. So you can put it in differential diagnosis of third nerve palsy, fourth nerve palsy, sixth nerve palsy, and any restriction of the eyes or restriction of the ocular motility, as we are going to discuss in the strabismus. You will also should consider myasthenia gravis. So, but if you are if you think about that, well, it will not be easy to diagnose if it is present in differential diagnosis of any strabismus or any ptosis. So we need to do some tests in order to just try to increase the index of suspicion for myasthenia gravis. What are these tests? The first test is called the Coogan-Littwich sign. Coogan-Littwich signs will be momentary upshoot of the lid while the patient is saccading from the down gaze to the primary gaze. So let's see here. This patient has myasthenia. Look at the right eyelid. When the patient is looking down and the primary position, there will be a momentary elevation of the right upper eyelid. This is the Coogan-Littwich sign. Let's see again. When the patient is looking down and the primary position, there will be transient upshoot of the upper eyelid. The next test is called the fatigability test. This is a test that will depend on to increase the exhaustion of the levator muscle. So ask the patient to look up for sustained up gaze. This will result in increasing the fatigability of the lid, leading to progressive ptosis. You see, the ptosis increase on the spot because of the sustained up gaze. The muscle, the levator muscle, is fatigued now. Let's see it again. This was the patient before the test. On looking up, the patient experienced fatigue of the levator aponeurosis muscle. So there will be progressive drooping of the left eyelid, left upper eyelid. Another test is the ice pack test. For the ice pack test is when the patient has ptosis like that, and when we are putting an ice pack over the eyelids, this will result in improvement of the ptosis. So this also test is very suggestive of the presence of myasthenia gravis. So this usually increase the conduction, increase the transmission of, or increase the action of the acetylcholine receptors over the target action in the muscle. Okay, so this clinical tests can be done in the clinic to increase the suspicion of myasthenia gravis. So what are the other investigations in order to order for patients for myasthenia gravis? First of all, we can order to measure the acetylcholine receptors itself, the anti-acetylcholine receptors antibody, and please pay good attention to numbers here because these numbers were asked before in the ICU exams. The anti-acetylcholine receptors antibody are present in 85 to 90% of patients with systemic myasthenia gravis, but only 50% of ocular patients of ocular myasthenia gravis. So not every patient that you will see with ptosis, variable ptosis, and variable diplopia will have positive anti-acetylcholine receptors. So for this case, we can do what's called anti-muscle specific kinase antibody. This test used for patients who have very strong clinical suspicion of myasthenia gravis, but they still have negative anti-acetylcholine receptors. So we can, for those patients, we can use the anti-muscle specific kinase antibody. What else? There is a test which is a dangerous test. It's called the hydrophonium or tensilon test. This test is now considered obsolete in the modern practice, and I'm going to tell you now why. And even it is not dangerous, it has a low sensitivity, like 60% only for myasthenia gravis. It can still show false positive results. So it can show positive result even if the patient doesn't have myasthenia gravis, as in patients with Lambert-Eaton syndrome or amyotrophic lateral sclerosis. So why this test is dangerous? This test actually inhibit the acetylcholinesterase. So they will increase the presence of the acetylcholine at the neuromuscular junction. So this will result in increasing or enhancing the muscle strength. So for those patients with the hydrophonium can cause overactivation of the parasympathetic system, and this will cause like undesirable side effects like fainting or dizziness or severe bradycardia or apnea, even cardiac arrest. That's why it's very dangerous. That's why if it is important to counsel these patients that this side effects may occur, and we have a crash cart are near, so that if the patient developed these symptoms, we can resuscitate him. That's why it is this is why it is not used in the modern practice, because we don't need this life-threatening investigation to check for myasthenia gravis, because we can now diagnose by much more easy and safer methods. What else we can do? What's called repetitive nerve stimulation. And repetitive nerve stimulation is positive in 75% of patients with myasthenia gravis, but it for the generalized, but for ocular, again, it is only 50%. And finally, there is a single fiber electromyography. Single fiber electromyography, so by repetitive nerve stimulation, we mean that we are stimulating the nerve itself and we see the response from the nerve. Single fiber electromyography, like we are stimulating the orbicularis oculi for cases of ocular myasthenia, and see the response. If the response is decreasing every time we are stimulating, so there is decremental response on repetitive stimulation, this will be very suggestive of myasthenia gravis, as it will have a sensitivity of around 88 to even around 100%. So single fiber electromyography is very sensitive for ocular myasthenia. So now you know all the investigations that you can do for myasthenia gravis. So what will be the problem? Or even if the patient has a myasthenia gravis, what will be the problem? Like if he has diplopia or if he has ptosis, what is the big deal? Well, the big deal, it is called myasthenia gravis for a reason, that it is a grave disease. It is a dangerous disease because it is not only it is not the problem about the ocular disease, but the generalized disease. Like those patients can have generalized myasthenia, there will be a fatigability or weakness of the muscles of respiration or muscles of the pharynx and larynx. These are red flags that this patient could have respiratory paralysis, which may lead to death. So we need to pay good attention for that. This disease should be controlled. And there is another aggravation of symptoms that is called the myasthenic crisis that also can be life-threatening. This myasthenic crisis will be increasing the manifestations of myasthenia gravis, which can be precipitated by a wide range of reasons such as pregnancy, emotional stress, ultraviolet light, and thyroid disease, and some medications such as chloroquine, quinidine, lithium, phenytoin. So for those patients can have dormant myasthenia gravis and will flare up by these drugs. So how can we treat those patients? Medically, those patients can be treated by acetylcholinesterase inhibitors or parasympathomimetics such as pyridostigmine or what's called mestinone. Those patients also treated by oral steroids and immunomodulator. They can also treat by plasmapheresis for patients with myasthenic crisis. Other thing or another surgical modality for the treatment of myasthenia gravis is to surgically remove the thymus gland, because it was found that around 66% of myasthenia gravis patients have thymic hyperplasia, and even a less percentage of them will have thymic tumor. And it was found that this thymus gland will be the source of the autoantibodies. So some patients will show improvement after removal of the thymus gland. Okay, so this is the treatment for myasthenia gravis. To summarize the myasthenia gravis, remember that it is a disease of Ds, a lot of Ds, like 9 or 10 Ds. It has a diurnal variation. It is more worse by the end of the day. It has a descending march course, meaning that it will start by the facial muscles or the lids on the eye, then descend to the larynx and pharynx, and then descend to the respiratory muscles, characterized by drooping of the eyelid, characterized by diplopia, dysphagia, dysarthria, dyspnea. When we stimulate a single muscle fiber, that will result in decremental response on repetitive stimulation on electromyography. And also don't forget to check for thyroid for the presence of dysthyroid ophthalmopathy. Okay, easy. Okay, so no questions? Okay, it's always said it is no news is good news. So no questions is good news. Okay, so the next thing or the next muscle disorder, it is called the chronic progressive external ophthalmoplegia. So we have Dr. Atif is asking any ocular treatment. We can use what's called the lid crutches. Lid crutches are elevators for the eyelid to just a symptomatic improvement or for symptomatic relief of the ptosis. So just a mechanical elevation of the eyelid, but not something specific, or there is no like eye drops or so. Okay, so for another group of myopathies, disorders are called the chronic progressive external ophthalmoplegia. And it is very self-explaining term. So it is chronic, meaning that it is very slowly it occurs over long years. It is progressive, so it will start and progress very slowly. It is external, so it is involving the extraocular muscles, doesn't involve the intraocular muscles, like the ciliary muscle or pupil or iris muscles. And ophthalmoplegia, meaning that there is causing limitation of ocular movement. So those patients, they are presenting with history of slowly progressive external or slowly progressive ptosis, and this chronic ptosis because it's chronic disease, and ophthalmoplegia usually start in the second decade of life. So it is a disease of childhood. So this disease or the spectrum of this disease is classified into other different diseases, like what's called chronic progressive external ophthalmoplegia, involving like what's called oculopharyngeal dystrophy. So oculopharyngeal dystrophy is a disease characterized by ocular involvement and dysphagia due to involvement of the pharynx. So for those patients, usually they complain of reduced visual field, reduced upper visual field because of the progressive ptosis. They can also complain of exposure keratopathy from the poor blinking. Again, there will be abnormalities in the all extraocular muscles, including the orbicularis, responsible for blinking. And the striking feature here, the most important thing here is that there is no diplopia. Why there is no diplopia? Because the patient has symmetrical affection of all muscles, or there is be symmetrical affection between both eyes. So if he looks to the right, to the left, up and down, there will be the same range of movement. So there will be no difference between both eyes and no diplopia. Another important specific entity of chronic progressive external ophthalmoplegia, which is asked very frequently in the exams, especially the ICU exams, that's called the Kearney-Sayre syndrome. Kearney-Sayre syndrome, it is a disease where there is ataxia, deafness, endocrinal problems, and sudden cardiac death. This is a fatal disease. That's why it is asked in the exams, because you should pay attention to this cardiac death. Those patients will have cardiac conduction defects that will result in sudden cardiac death. So those patients are usually, like as I told you, in the first to second decades, present with bilateral symmetrical ptosis. This is not very symmetrical, but actually this is a patient with chronic progressive external ophthalmoplegia due to Kearney-Sayre syndrome. The patient will have limitation of ocular movement in all directions of gaze. This limitation is symmetrical, so there is no diplopia. For patients with Kearney-Sayre syndrome, there will be more systemic associations to pay attention to, as they will lead to death. So those patients will, or generally speaking, the patients with chronic progressive external ophthalmoplegia, they will have ptosis with poor levator function. They have loss of Bell's reflex, which is what's the Bell's reflex or the Bell's phenomenon, which is the rolling of the eye when the lid is closed. They will have symmetrical ophthalmoplegia. And for other associations with Kearney-Sayre syndrome, it will include pigmentary retinopathy, sometimes referred to as a salt and pepper retinopathy. Those patients have pigmentary changes in the retina, which will be helpful for diagnosis of Kearney-Sayre syndrome. They will also have other syndromes such as cerebellar ataxia, deafness, endocrinal disorders, diabetes or gonadal dysfunctions. This also should be inquired and looked for those patients. For those patients, how can we diagnose? The most important, which is asked always in the exams, is the cardiac workup. Those patients, we need to refer to a cardiologist to do a ECG for, again, this was asked before, which is the most important investigations for those patients is ECG in order to diagnose the heart block, because those patients will need a pacemaker in order to preserve their heart rate, which is a life-saving for them. And for diagnosis, we can do electromyography and we can do muscle fibers, which will show what's called the raked red fibers. Or there will be, these fibers will be like broken. This will cause or will called raked red fibers. Raked red fibers is again one of the diagnostic criteria or diagnostic clue for the for reaching diagnosis of the Kearney-Starr syndrome. And of course, for those patients, should do ptosis repair to prepare the ptosis for them. It's also worth mentioning that the Kearney-Starr syndrome is inherited by a specific pattern of inheritance, which is called the mitochondrial inheritance. This is asked in the basic part or in the basic exams, but it could be also asked in the clinical exams. So chronic Kearney-Starr syndrome is diagnosed by, or it is one of the mitochondrial diseases, in which the mother will pass the abnormal gene through their mitochondria to their male children. Okay, so this will be like the end of the lecture today. So it will not be very long actually, because there were some topics that I prepared for migraine. For the nystagmus, it will be discussed in the strabismus. I thought to discuss the nystagmus and the strabismus, it will be much better to discuss the treatment of nystagmus or the surgical treatment of nystagmus, which will consist of resection of the horizontal recti. This will be much relevant to strabismus than neuro-ophthalmology. And there will be like little topics of the headache and the migraine. So we'll just I will maybe cover them in the beginning of the lecture of the first time, or maybe I'm going to record them and I'm going to upload them in the website, so that if you have any question for them, you can ask in the group. So by that, we will concluding the neuro-ophthalmology, and we will start the next time the strabismus, we will start the strabismus the next time, so that it will be connected to the neuro-ophthalmology. Both of them are interconnected to each other. So we will discuss the comitant and incomitant strabismus, including the paralytic and restrictive strabismus, and the surgical treatment of strabismus. And followed by the lecture after will be for pediatric ophthalmology. And then we will have a lecture MCQs for discussion of the neuro-ophthalmology MCQs, pediatric ophthalmology, and strabismus MCQs. Thank you very much. Dr. Atif, when will the app be functional? Well, it should have, as I told you, around 48 hours, as I told you in the group. Thank you, Dr. Ahmed. Is there any chance to see the PowerPoint slides on the website for revision? Well, it's already present. If you find me that, I will discuss a lot more than the PowerPoint. So it will be much more beneficial to listen to the lecture themselves. So, but for the PowerPoint, I don't believe that it will be helpful. It will be the helpful is just listening to the information, because you can see that I discuss a lot in diagrams, and this will not be provided by the diagrams will not be self-explanatory. No MCQs. No, we said that the MCQs, as we mentioned in the table that that was even present before the registration, that there will be one MCQ lecture after 2 chapters. So basically the neuro-ophthalmology and the strabismus are connected to each other. So there will be MCQ lecture covering 3 hours of discussion for these 2 chapters. The cornea and lens are also connected to each other. So there will be another MCQ lecture for both. Then uveitis, retina, and glaucoma, there will be every 2 chapters, there will be a generalized MCQ lecture for those 2 chapters. Dr. Atif, please, we need it urgently. Dr. Atif, what do you need urgently? I don't understand. Dr. Wala, will start with comitant or incomitant? We will always start with comitant strabismus. Thanks, you're welcome. Thank you, you're welcome. The app, Dr. Atif, you still have the lectures present on the website. So maybe those of you who attended with me the FRCS3 course, they always had something against the application. They don't like it and they have objections toward it. The strange thing about you that you prefer the application over the website, unlike the FRCS3 group. So Dr. Maral, maybe you can relate to that. How many questions in the MCQs? It depends. There is no fixed number. I will try to bring as much as possible. With particular attention to the clinical MCQs that appear in the clinical ICU exams and the FRCS2 exams. Dr. Atif, there is no fixed number. It depends on the discussion. Like I discussed the questions. So there are questions that need discussions, other questions don't need discussion, or they are straightforward. So there is no fixed number, or even there is no estimate number. دكتور اسلام الابلكيشن احسن بالصوره بالعرض مش بالطول. Yes, of course. Yeah, this is something that you, if you don't know, you can always watch the lectures in the application in the landscape mode. You just do full screen. There will be a button for full screen that will enlarge the window for making it landscape mode. So it will be by horizontally oriented. So makes it much more better. So if you don't know it, I'm just telling you for your information. Dr. Wale, how long the lectures will be available for us to watch after the course end? It will all the lectures will be available from day one of the for 4 months from day one. Like we started in 29 of November, so they will be available to 29 of March. Of course, 2022. So all your questions are not or off the topic today. Okay, the migraine, yeah, as I told you, I'm going either to, I'm still thinking if I'm just going to like record it as offline and present to you, and if you have a question you can ask, or I may discuss it in the beginning of the next lecture. Okay, any question? So how is this lecture today? You didn't tell me what is your yes, Dr. Mara, yes, visual loss also will be discussed. Yeah, the visual loss, yeah, will be discussed as well. For the transient visual loss, this will be the second topic, yeah. I'm planning for it actually, but I just forgot to tell you about. Don't worry, I didn't forget it. Thanks a lot. I hope that this lecture was helpful for you, and please don't postpone your study. So you have you have like a week till then we discuss the MCQs. I hope that you are ready with the neuro-ophthalmology and strabismus and pediatric ophthalmology before the MCQ lecture. Thank you, and see you next lecture.